Hi, how are you doing?
I think the time change has thrown some people off.
I
But,
know.
but that's okay. Your series will continue. It'll be part of the series.
And then, we can, it's recorded and it's posted, so it doesn't,
Yeah, I know it's more convenient for docs to get up early.
Yeah. Well, we had I'm at a meeting today, actually, conference today, and there's a session that starts at 7 a.m. I'm in Alabama.
Okay, let's get going, okay?
Yeah, go ahead.
10, okay, 10. Hold on. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. 2. Good morning, this is Dr. John Bennett broadcasting from Miami Beach. We have another in the series with SIDDIQ's NTV channel. And he was nice enough to start early. Hello, yes, Rabbi. So we'll let him start off proceedings. He's got another meeting after this. Okay, FARHAN, welcome.
Hi, thank you. Yeah, you're right. We've done some time changes and some days off here and there based on the schedule. I'm actually in a meeting in Alabama today, and there was a session starting early, so I wanted to make sure I do this and not miss the opportunity. So let me start sharing my slides, but just as a background, so last time we were talking about our trip that we did um, uh, for our trainees, the seed program trip. Let me see here. Okay, so today is the that second part of that travelogue, and I have two more cases to show, which are very interesting cases. So, as you remember, just to remind everybody, this is a project seed program or project started at University of Missouri. The idea was to enhance the exposure of United States neurosurgical trainees to not only diseases that their exposure or experience is diminishing, but also to diverse socioeconomic cultures and learn how things are done at other places, and also the trainees in LMIC countries to be able to benefit from US experience. So it's kind of a both-way streak. And I'm not going to repeat all these slides quickly, but one thing I wanted to show you that we didn't talk too much in detail about last time was that when we asked the trainees what they're going to do in their future, and then we also asked them how much cerebrovascular, and I'm going to only going to focus on cerebrovascular because that's my area of interest, but it applies to other fields as well, such as skull base and maybe some pediatrics at the same time. Um, so what when we ask them how much cerebrovascular experience they have had 3 months before graduation up until that point and what they're going to do after they finish their training, we found out that when trainees are exposed more to cerebrovascular, there's higher chance that they will actually practice cerebrovascular neurosurgery. And that number needed to treat, I think that slide is missing from, oh, actually here. So the number needed is about 29 aneurysm clippings is required for 99% probability that the trainee will clip aneurysm in their practice. So obviously volume matters. We understand that, but here we are showing with the statistical examples. And then when we add each extra aneurysm, the comfort level of the physician or the trainee goes up by 7.71%. And the one important thing to understand from this data is when we ask them very granular data, we ask them how many aneurysms they saw being clipped, how many aneurysms they assisted, and how many surgeries they actually did microdissection and put the clip on the aneurysm. So here we found that just assisting in an aneurysm clipping surgery is not important to be able to predict whether that surgeon has comfort level and will be able to do this surgery in their future. So you actually have to be doing that surgery or microsurgery to be able to be comfortable with at least that part of the disease that we deal with. So here are our U.S. sponsor once again, me, my other partner, Kellen Quincy, and one of our trainee that you have met before in this channel, Michael Ortiz, who provides skull-based support for this. And we, on April 17th, our 11th trip was to Punjab Institute in Lahore, Pakistan, which was a fantastic experience for all of us. And these were the two trainees. This was their first trip in the SEED program. Kaushik, who is a trainee at University of Missouri, and Mustafa, who's a trainee at UT Memphis. Actually, Kaushik has done one trip with me in Kenya, but he was more junior at the time. This was his true senior exposure. And here I'm going to present two cases that I did during this visit. I've gone over two other cases before. This is my, let me see what happened here. Okay. Slides are going forward. Okay, so this is one of the very interesting case that I wanted to present that we saw and treated during our trip. This is a delayed clipping of ruptured carotid terminus aneurysm. A little bit of the story: a 43-year-old man who presented with subarachnoid hemorrhage, ruptured aneurysm, and here in this picture you can see that this was earlier on during his presentation, probably on day 2 or day 3, and you can see that he already has a little bit of hydrocephalus. And his clinical picture at the time, this is again going back into the records and knowing that sometimes the records are not very clear, that he was awake alert, oriented but slightly drowsy. Now, I know in United States, this person would have gotten an EVD right away if he has hydrocephalus, subarachnoid hemorrhage. We tend to be very aggressive with that. But one thing that I learned is that, perhaps what we don't know is the natural history of immediate hydrocephalus after subarachnoid hemorrhage. Because this same gentleman, 3 weeks later, without an EVD or lumbar puncture, has a CT scan, subarachnoid hemorrhage is resolved, and you can see the ventricle size has come down and hydrocephalus is improved. And that's something that I had not seen before. So I think we inherently treat all hydrocephalus associated with subarachnoid hemorrhage, but don't actually sometimes don't actually look at the clinical picture. And the clinical picture is the patient is doing, on reasonably well at the time. Sometimes perhaps it's okay to just follow them. So here, this is a very interesting example where this patient had hydrocephalus on his day 2, but without treatment, that hydrocephalus actually resolved and it was gone. So anyhow, let's go to the video. Oh, actually, first we'll go to the CT angiogram. So this was the aneurysm, and you can actually see a little bit of it if you focus in this slide on the CT scan. You can see a little bit of that hyperdensity, which is probably some blood or acute blood, or could also be thrombus in the aneurysm that is visible on this CT scan, which gives you an idea where the aneurysm is going to be. So we did the CT angiogram, a 3D CT angiogram, and it showed large size supraclinoid, large size carotid terminus aneurysm. The geography looks like it's coming more from A1 rather than the actual terminus. So you could argue that this is an A1 aneurysm, superiorly projecting large A1 aneurysm. But for the sake of simplicity, we'll just say carotid terminus. And then also, interestingly, there's, which the radiologist missed, but we did see that there is a small bump on the MCA as well. The M1 segment is fairly short, so it's all fair game through supraorbital approach. And this was actually my first carotid terminus aneurysm that I've done supraorbital. And in the past, I've done all of them through a little bit more lateral approach using a via mini tenonal craniotomy, but supraorbital I had not done. And my concept at the time was that we have to come a little more lateral and follow along the MCA and then clip the aneurysm so we're able to see actually behind the aneurysm and make sure that there are no perforators caught in that aneurysm. So let's go to I'm going to stop share here and go to my video. And then let's go to share again. Here. Are you able to see the video?
Yes, we can see.
Yes.
Great. Let's play the video. So left-sided supraorbital approach, same procedure that we always do. You go in and when you start seeing that skull base going into the clinoid. If you're ever unsure, go straight at the clinoid and then start going medial. Here's Kaushik operating and with me, and then we do the same thing that we always do. A lot of dissection, arachnoidal dissection to release CSF. And we're just doing this process slowly so we can really have the brain fall in. Here you can see the third cranial nerve going into the roof of the cavernous sinus. We're seeing ICA. We're seeing, and now with some retraction, we're able to get an assessment of where the ICA terminus is. So at this point, we decided we're going to do the Sylvian Fisher opening. So at this point, the brain is shrunken and the Sylvian fissure has fallen down into the view. So we started with the anterolateral part of the Sylvian fissure. This is again a 3-week-old rupture aneurysm. So you can see a lot of hemosiderin. The vein once again goes towards the temporal side. And when you go deep, usually there's always 1 or 2 tributaries of the vein crossing, which a lot of times I try to preserve, but sometimes you may end up sacrificing. Here we have now A1, and we are seeing a little part of that neck of the aneurysm. And we have the neck of the aneurysm exposed on the other side at A1 as well. Some hard bands, arachnoidal bands, or hemosiderin bands, they are all cut sharply. And so once we are once we have some control of this carotid terminus aneurysm, then we go back to the MCA and we continue to dissect MCA and dissect those veins away, trying to carefully make sure that we're not uh, sacrificing any of the veins. And now we're starting to see a little bit of that abnormality. Still not very sure because the images were not very clear. We didn't do an angiogram, but here we're starting to see this blister-like MCA aneurysm. And what I do is I usually expose the aneurysm, then I see how much retraction I need, and then I go back on the Sylvian fissure to get that much exposure. And that's what I'm doing here. Because I don't want to pull too much on that frontal lobe. And then I go back into the Sylvian fissure and more laterally and continue to expose it. And both from both directions, inside out. But most of my dissection is always sharp. So now we're ready for temporary clip because this is a very dangerous looking thin wall blister type aneurysm. So once we put the temporary clip, we can be a little bit more aggressive. And now we're trying to find where those uh, M2s are and uh, clipping this aneurysm. So defining the neck, and then aneurysm actually was much bigger than what we thought on the on the 3D angiogram, and again provides you with the value of an actual conventional angiogram prior to the surgery, and you could be perhaps maybe better prepared for that if you do it that way. But anyhow, we placed a temporary clip because we want to be a little bit more aggressive here. You can see that bridging veins are still preserved. With the under the temporary clipping, we placed the clip, and then this was after 2 or 3 attempts, and we were finally able to place a clip on the dome and kind of flatten that part of the MCA bifurcation. We can see both M2s open. The distal M2 had a little bit of a kink, or sorry, temporal M2. And I wasn't very happy with that. I don't like to have kink in the vessels when we clip. Unfortunately, a lot of times there is a little bit of change in the direction. Here, proximally, we thought maybe we could put another clip, but at that point I decided not to, and I'm going to stop the video here. So the thought process here was that is this kink, because we don't have ICG, we don't have monitoring, we don't have angiography intraoperative, is this kink bad enough that we should stop? So I thought maybe there is some spasm here. I'm going to put some verapamil on the vessels and allow them to wait for a certain period of time and then go back and observe again and see if the kink has resolved. And if it's not, then I'm probably going to reposition the aneurysm clip because I did not want that kink in the vessel. Remember, if there is a kink outside, there is almost double the amount of kink inside because the outside vessel does not always correlate to the intraluminal pathology. So now, anyhow, we decided to go to the carotid terminus aneurysm, and then we'll come back to the MCA in a few minutes to observe again. Let's start the video. So now we are defining the neck. And here you can see with the supraorbital approach, you can actually get behind the aneurysm quite well. And the video is not showing very well, but you can see this 2 small perforators. So I decided, since it was a big aneurysm, I decided to clip this one also under temporary clip. With temporary clip, I was able to expose a little bit more of the aneurysm. The neck is small, but the dome is very wide. So we put the first pilot clip. And the idea here is that we don't want to cramp the bifurcation. So I'm trying to create a little bit of room between the clip and the bifurcation. And as you land the clip, you want to make sure that you're not kinking any of the vessels. So the vessels look okay. And then we look at the depth of the clip and we see that it's not all the way down. So then I open it and I kind of wiggle it, and you can see that perforator on the left side, and we kind of slowly go around that perforator and advance the clip more. And now the configuration is telling me that the clip is complete. It's all the way down. The perforator is visible. There's unfortunately no ICG here, so we just have to rely on our visibility. And the A1, which I was a little bit more worried about since the aneurysm was coming more from A1 than the true bifurcation, looks okay. Then I go back to the MCA to look at that kink, and the kink is still there, but look how the vessel is plump and red, and it's filling. So based on that, we decided to leave it alone because this was a small aneurysm, and I did not think that I could replace a better clip or configuration for this. and kind of relying on our luck a little bit here. Patient woke up great, no neurologic deficits, and did very well, and was actually discharged the next day. I think that was a good learning experience for all of us. About active in uh, real life thinking about how to approach different pathologies and changing your plans and making sure that you always if there is a doubt, you always go back and just use your best clinical judgment and assessment. And if generally if the vessel, middle cerebral artery vessels or any other large vessels are red, plump, and pulsating, they're generally okay. But it's not always a guarantee. So that's why we have the safety, some of the safety mechanisms that unfortunately sometimes we don't. And when we don't have those mechanisms, it's a little bit of it's a difficult feeling to leave the patient behind like this, and kind of hope for the best. But in this case, it actually worked well. All right, let's go to the next one. So I'm going to stop sharing here. So the next case, continue to share. Okay. So the next case is a little bit unusual. It's not my, sorry, this is, yeah, it's not my favorite surgical case. I was a little bit lost here, so I want to present that as well. I didn't and I'll show you why I was lost and why I had so much difficulty dissecting this aneurysm and clipping it. So this is a 61-year-old woman who presented with subarachnoid hemorrhage. She was, again, Huntington has 3 at the time of presentation, with mild hydrocephalus and a lot of interhemispheric blood. And so the idea was that this is most likely distal ACA aneurysm rupture or DACA aneurysm rupture. Um, Patient made great recovery, and we're seeing this patient about 3 or 4 weeks out. This is the CT angiogram. And if you focus, I don't know if you can see my marker here, but there is the A2 and A3 junction, there is an aneurysm with a dome, and then a base. So it's kind of like a Mickey Mouse, uh, or a snowman, actually, like aneurysm. And just by the shape of this vessel, I know for sure that this vessel is hugging the anterior genu of corpus callosum, and and that's what we have to expose. So this is an important thing to remember when you're doing DACA aneurysms. The proximal, you can see the distal, you can see the aneurysm, you can see the distal vessel, but in order to get to the proximal vessel, you have to go around the corpus callosum a little bit, and sometimes you even have to just do a little bit of area of corpus callosum resection sometimes to see, and it doesn't cause any neurologic deficits. We know from our interhemispheric approaches that corpus callosum, small amount of corpus callosum resection is very well tolerated, because there's a lot of redundancy there. On the AP, you can see once again this aneurysm, but it's hard to, without an angiogram, it's hard to tell which vessel it's coming from. So since most of the blood was on the right side, we assumed that this is come from the right side. It doesn't really matter because we're going interhemispheric. We'll see both vessels. But if you know beforehand, then you know which vessel to focus on. But the important angiographic factor here was that the other, or the contralateral, or let's say in this case, what we're calling the left side, is higher and above the level of the right A2. So we'll find the left one first, and then we'll find the right one. And because this aneurysm was slightly more anterior, our typical interhemispheric craniotomies are kind of located just around the coronal suture, usually about 1/3 in front or 2/3 behind, and sometimes the opposite, 1/3 behind, two-third in the front. This one, we made the entire craniotomy in front of the coronal suture, and it was only a 3 centimeter craniotomy, but we did make sure to expose the sagittal sinus so that we could retract it medially for better visualization. So let's go. So that's the surgical approach we chose. Let's go to the video. All right. So here we've started the section already. So the the first vessel that we're seeing now, we know that this is not the vessel that has the aneurysm. So this is we're seeing a lot of hemosiderin, some subacute blood. This is 3 weeks out. So we dissect this vessel, and we know that the actual vessel which has the aneurysm is actually deeper. So we continue to go deeper, go through that blood, a lot of sharp and blunt dissection again, and as we go deeper, we also expose anteriorly because it gives us a little bit of an idea of how much retraction we need. Now, this surgery was done in supine position. Um, so here we're getting close. Sometimes it's hard to differentiate between corpus callosum and other gyri around. So now we're starting to see the vessel that the aneurysm is coming from. And as soon as we get to the vessel, we start seeing the dome of the aneurysm. So that's one of the biggest issues with the DACA aneurysms, that you always arrive at the dome of the aneurysm. So it's an unnerving feeling. You don't have proximal control yet, or you get proximal control. So in this one, the dome looked very hard, and I don't know if it was thrombosed or the walls were too thick, but the dissection was very, very hard in this one. So I'm trying to separate the two distal ACAs. I'm trying to go on the left side of this aneurysm, and all of this tissue was very, very hard and difficult to dissect. And I didn't want to be too aggressive. But what I'm trying to do is, before I expose the dome, I'm trying to find the proximal control, but I was not able to do that. So then I had to go back to the dome, and here you can see the dome is stuck to the medial wall of this brain or cingulate gyrus, and you can damaging the cingulate gyrus obviously is not a great idea because it's involved with the hippocampal circuitry, and memory could be affected. So we have to be careful. Invariably, with these aneurysms that are stuck, there's going to be some damage, but we have to be extremely careful to prevent that. So here, I'm trying to make sure that we don't cause any damage to the cingulate gyrus, and continue to expose there's small vessels attached, which we're dissecting. And then I try to go around the aneurysm again from the left side, and the anatomy is still not very clear. I couldn't really get a clear understanding of the anatomy here. I thought I had proximal control, but it obviously is not looking great. So then I go back, and I see several different dome-like structures of the aneurysm, but I wanted to be more aggressive. So at this point, I decided I'm going to isolate this dome, which I believe is ruptured, and then I'd be more aggressive. Again, I don't have proximal control yet, but I want to make sure that this dome doesn't bleed. And again, trying to find that proximal control, but struggling, not able to find. So I partially clipped the aneurysm so that I could be aggressive with the dome. So this is that head of that snowman. So once this clip goes on, then we can be a little bit more aggressive. This aneurysm was really stuck to all surrounding tissue. And so now we could be more aggressive. Once again, sharp, blunt dissection to start exposing around the aneurysm to get to the under surface of it, so we can see proximal control. Here we're separating the contralateral A2 vessel or distal ACA vessel, trying to get a little understanding of how I'm going to clip. I was very confused with this aneurysm. I had a lot of difficulty. So at some point I was able to, I don't know if I saved that in the video, I was able to see proximal control. And then I thought, okay, I'm going to do some stacked clipping, um, trying to collapse the dome of the aneurysm, the secondary dome, or actually the primary dome, and see if I can find that proximal control around it. And the aneurysm the clip keeps slipping because there's a lot of atherosclerosis in the aneurysm. So as you can see, I'm struggling to have that clip hold on. And what I'm trying to do is, use the clip to flatten the aneurysm so I can go. Yeah, so once I flatten the aneurysm, now I can go around that dome a little bit more because the mass effect of the aneurysm is now improved. So as I go, now you can see the proximal control. So finally, I got the proximal control, and it was hard to see from the other side, but you have to go on both sides to actually see. These aneurysms are very challenging, and they're not my favorite. So now we have good proximal control, and we put a temporary clip on the proximal vessel. Now we can be a little bit more aggressive, but I still couldn't, because of the thickness of the dome, I was not able to collapse it. In retrospect, perhaps I could have punctured the dome and really bipolared it and collapsed it, and then would have been able to put one clip on it. I tried to do bipolaring. The aneurysm was not budging. It was I thought there's thrombus. I'm always very scared when there's a lot of thrombus in the aneurysm because I don't want that thrombus. I don't want the clip to smash the thrombus into the parent vessel. So I decided I'm going to do some stack clips on this. First I did a right angle clip to isolate that dome that I believe ruptured. We still have the temporary clip on the proximal vessel, and then I placed some stack clips. I actually used up all their clip inventory, and used up and I did like 4 stack clips and got a very good angiographic result afterwards. I don't know if I have a post-op angio on this actually. Maybe I can find it. Oh yeah, here it is. I have the post-op angio. I'm gonna send it to. So you can see, different ways of clipping aneurysms. This is not the most elegant way. I hate to say, but sometimes you just have to do what the best is presented to you. I'm going to stop sharing this here, and I will go back and see if I can find that post-operative angiogram picture. I should have done that earlier. Let's see here. So a lot of times when I go for these international trips, I don't get post-operative angiograms, but this one I really wanted to because I was not 100% sure how well the clipping was, and um, it actually was pretty satisfactory. You can see, let's see here. So I hope you can see this angiogram here. Um, So there is a little bit of that, the little bit of that residual. It's not significant, but it is there. And all the other vessels are open. You can see that there is a branch vessel coming from the neck of this aneurysm, which is also open, which is what I was most worried about because I didn't want to incorporate that. Would have certainly caused a stroke. So it's an okay result. It's not the best result. I'm not very proud of it, but it is what it is. Sometimes. These situations are very difficult, and you just have to do the best that you think you can. So with that, I will stop sharing, and I would open the forum for any questions if anybody has, and we'll go from there.
Thank you, Farhan, for being dedicated enough to present so early. So
Sure.
Uday is here, our favorite student. Uday, do you have any opening comments? You there, Uday?
Yeah, actually, I'm a bit busy in the hospital right now, but they were very, very nice surgeries, and I really appreciate that the keyhole approaches from that sir said, like in interhemispheric keyhole approaches, and I really appreciate this delayed clipping. I think it's a wonderful idea. We don't need to make big anatomies or big incisions.
Yeah,
Supraorbital and this interhemispheric keyholes are very nice approaches,
yeah, yeah, yeah. I
and
think
they
I think
have
it's
very little brain retraction and don't need to use a retractor much also. It's beautiful surgeries.
yeah. I try to avoid retractor. They're not. I mean, very few situations where I use retractor. I mean, I've used it, but very sparingly. Um, the biggest problem with retractors is you put it on and then you forget about it and it stays there and your hand hits it and you invariably cause more damage from the retractor than if you didn't have. It does give you a good view for a short period of time, but then it eventually degrades everything. So that's why I don't use it. But you're right, the keyhole approaches, I think you just have to get over that fear of, and be able to, and eventually become comfortable enough that through a small hole you can approach and move
Yes, yes.
uh, in a way that you can approach most pathologies. And it's a little bit of a learning curve. You have to get yourself into it. It's always a great idea to start in the cadaver lab. But in the cadaver lab, we've been able to see that we can do a whole lot more because, of course, that brain is fixed and you have more room for. But
I wonder how much of terminal approach will be left now. Like if you're doing MCS also from supraorbital, ACOM also from supraorbital and interhemispheric, there's not much to do aneurysms from the sterional lateral.
Yeah, large aneurysms, large MC aneurysms, thrombosed MC aneurysm will still be, I think that's where it will still be. But with endovascular approach becoming more and more predominant, most of the ruptured aneurysms actually are small aneurysms. And then we have to compete with endovascular. So if we have to compete, we have to be minimally invasive. And the
Yes.
advantage of supraorbital is all the supraorbital that we have done so far 99% of the patients leave the next day, and it's the same as endovascular. There's very little discomfort, and the hospital stay is very short. So you can really go out and say, there is no difference. This is also minimally invasive, similar to endovascular. You have to understand when people talk about endovascular being safe, it's a relative term. It's not really safe because the risks and the complications of endovascular are similar, same, maybe perhaps sometimes even more complicated than open surgery. But again, I'm not saying that open surgery is the best approach. But what I'm saying is that in your hand, if you know both things, you can better judge what is best for that patient. And so I think that's kind of what I try to advocate for. Or in a group practice where you have physicians who do different things, but they trust each other and understand each other's capabilities. Only in that case, you can offer the best approach to the patients.
Yes, sir. Thank you, sir. Very nice surgery, sir.
All right. Thank you. Thank you, Uday. Hopefully, we'll see you again with some more.
Anybody else have any comments or questions?
Hi, Farhan. I'm Ravi here. Am I audible?
Yes,
Yeah. Mhm.
It's nice surgery as always.
Yeah.
Nice surgery. It was gone through keyhole approach.
Yeah.
And in the first case, you told about hydrocephalus and it was resolved, of course. You didn't try for laminate terminalis approach, laminates opening up the laminate terminalis in there.
Yeah. Well, so when I saw this patient 3 weeks out, the hydrocephalus was resolved already, and to my surprise, it was resolved. And I've seen that frequently enough that hydrocephalus eventually improves. Of course, we don't. Again, like I said, we don't know the natural history. I don't. If the hydrocephalus is resolved, I don't typically go and open the lamina terminalis. It's a good approach. I'm a lot of times for MC aneurysms, if I'm doing supraorbital. I do open lamina terminalis just to have the brain shrink enough or fall enough away from the craniotomy that the lateral part of the Sylvian fissure exposes itself. But in this case, I didn't do it because there was enough brain retraction. I didn't have to. The MC aneurysm was very small. I knew that I didn't have to do a whole lot of MCA dissection. So, but like you said, I think if you know how to do it and how to get to lamina terminalis, there's never a wrong idea to not do it because there's really nothing neurologically important there except that you get more CSF release and then hopefully keep that pathway open for more CSF release.
Okay. It's a nice point. And I saw most of the times you are using D clip instead of that classic Yasagil variety of clips. So are you comfortable with the more of a D clip types?
Um, yeah, I think when we go for like our international trips, of course, whatever is available, we have to use that. Uh,
Okay.
but in my own practice, I mostly use Sugita clips. The one disadvantage of Sugita clip is that the applicator is very big and it has, so I have to use different shapes so that I can see the aneurysm clip. I use a bayoneted clip very frequently. And then I use sideways clips also very, very frequently. So, so I think those are kind of the main clips that I use. The Escolab clips are very nice because the clip applicator is inside out, and so you don't have a big mass of clip applicator in your view. So I think they are actually very good clips. The one thing that I like in Sugita clips a little bit more, and if you've seen them under microscope, the tip of the Sugita clip prongs is a little bit more kind of ergonomic and designed in a way that it looks a little bit less traumatic or a more atraumatic compared to the Escolab clips. The Escolab clips, the tips are blunted, and Sugita clips are a little bit kind of tapered. So I feel that Sugita clip around the areas where or aneurysms where the neck is really the parent vessel and neck, there is not a lot of space. The Sugita clip does a little bit better job than Escolab clip because the Escolab clip sometimes pushes the aneurysm with it. So it's kind of my personal experience. I don't know if that's entirely true. Other people have different type of experiences with clips. I think both are very, very good type of clips, but certainly they have some advantages and disadvantages.
Okay. Okay. Nice one, and nice videos. Thank you.
Thank you. Thank you so much.
Thanks for coming, Rabbi. Where you from, Rabbi?
I'm from India, Bhubaneswar, India.
Oh, welcome. We have these every Sunday,
Every other Sunday.
every other Sunday. I'm sorry about
Okay.
that.
Thank you.
Yeah,
Thank you.
and if you have any cases you want to present, you're welcome to. I mean, the idea is
Yes.
to present different techniques. Why don't you email me and John, and we can discuss through kind of our idea how we present this, and maybe next Sunday you could present a couple of your cases. The idea is to focus on technique part because a lot of times you go to different videos or conferences where people show glimpses of great surgeries, but for trainees you never really understand what is the thought process at the time and why you're doing what part of the procedure. So I think that's what I want to focus on this channel, the intricate, deep, or those key parts of the microsurgical technique.
Yeah,
Sure,
we'll
you can do
work,
that. Thank you.
All right,
we'll work
sounds
on
good.
growing in the community. I just mentioned to Uday the same thing. If he has an interesting case, he attends here every 2 weeks. So you're welcome also, Uday, for anything that brightens the field.
Yeah, I sent my email on the chat, so send me an email if you have some good cases. I'll be more than happy to host and see and maybe critique. And I think that's how we learn. We talk about things, we do things, we show it to other people, and that's how we learn. I'm learning as you are. And so I think that's an important part.
Yes, a good solid start. Okay, Doc, I know you're busy today. You have another conference now.
Yeah.
You're working hard. So some people, that's not neurosurgeon's dream. 2 conferences in a row. Okay, we'll see you in 2 weeks. Thanks for coming.
See you.
Thanks for
Bye.
presenting.
You're welcome. Bye.
Bye-bye. Let me
Bye-bye.
just turn this off. Turn, Stop recording. And we're going to stop the YouTube.